Thank you, operator, and thank you to everyone for joining us for today's COVID-19 daily media briefing for May 1st. Governor Walz is not on today's call. Today's agenda will start with an update on the COVID-19 outbreak from Minnesota Commissioner of Health Jan Malcolm and from MDH Infectious Disease Director Chris Erzman. Following that, we will hear from Homeland Security and Emergency Management Director Joe Kelly. Following the speaker's opening comments, we will have time for media questions. To keep our speakers moving to their next obligation, we will need to conclude today's call about 2:45. With that, I will now turn it over to Commissioner Malcolm.
Thank you, Mike. Good afternoon, everyone. I will go through the data brief again very briefly. Globally, as of this morning, we were approaching 3.3 million cases and 234,000 deaths. In the United States, reporting more than 1 million cases and 63,000 deaths. In Minnesota, we had an additional 596 laboratory-confirmed cases reported from yesterday. So we are now at 5,730 cases in Minnesota. That was on a very much increased testing volume. So as we've been forecasting, as we test more, we're going to see more rapid growth in the daily totals as we have been seeing. We also are announcing today an additional 28 deaths from COVID-19, bringing us to a new total of 371 deaths in Minnesota coded as COVID-19 deaths. Again, today, 24 of these 28 deaths occurred in residents of long-term care facilities. We're going to talk a little bit more about the questions that you all have raised about the percentage of deaths coming from long-term care in Minnesota later in this call. The demographics of those individuals passing away with COVID-19 include 18 in Hennepin County, 4 in Ramsey, 2 in Olmsted, and 1 each in Anoka, Benton, Dakota, and Washington counties. This reflects 6 people in their 90s, 10 people in their 80s, 5 in their 70s, 4 in their 60s, and 3 people in their 50s. And as of today, 2,282 total patients have been released from isolation. There are currently 369 patients in the hospital, 118 of them in intensive care. And we have noted in recent days the relatively lower rate of increase in intensive care patients relative to all hospitalizations, which we consider to be a positive sign. In terms of what I mentioned earlier, the ramp up in testing, which is so very important to our ability to get a truer picture of the spread of the disease in our state, and that is going to continue to drive daily numbers up at a much more rapid clip than we had been seeing, that we were able to conduct 4,124 COVID-19 molecular or PCR tests yesterday. And this is going to continue to help us not only make sure that, as the governor has said, every person who is symptomatic in Minnesota is able to get tested, but it will also help us to fine-tune and focus our efforts to track down hotspots to help stop the spread of the disease. In order to keep up this pace of growth in testing, we are going to need increasingly large shipments of testing materials throughout the state, both the materials on the front end at the care delivery sites for people, healthcare providers to collect the specimens, as well as the laboratory materials needed to process those samples on the back end. We've been working hard through the State Emergency Operations Center, and Director Kelly might want to comment on this, to increase supplies. You've heard us talk about the importance of respirators and masks and gowns and gloves, but we've also been focusing on laboratory-related supplies through that effort and working with FEMA and all sources that we can find to increase laboratory supplies as well. And I just was told this morning that the state's going to begin receiving about 47,000 nasopharyngeal swabs per week through a FEMA channel, which will mean 190,000 swabs for the month of May, which will help to just, again, solidify the capacity to fully maximize all of the ability that the health systems around the state have to be collecting samples and processing them in their own labs or in the labs that they use, and then, of course, with the backbone of the University and Mayo that we announced last week. So I think that is it's very good news that the testing volume is going up rapidly. We have our eyes on how to make sure we sustain that and continue to grow it to meet all of the testing goals that we've laid out in our testing strategy. Happy to answer questions about that later in the call, but right now I'd like to turn it over to Director Chris Ayersman.
Thank you, Commissioner. I'd like to talk a little bit about the many questions that we are receiving about the high percentages of deaths in long-term care facilities. We know that long-term care facilities present a special set of considerations and risks because they are congregate care settings serving residents who generally are of advanced age and often have one or more underlying health conditions. Given the nature of this pandemic, one would expect that these settings would have a heavier burden of disease and death. That is why we've been working so hard since this all started to share information, guidance, and support for long-term care facilities. We sometimes get questions about how Minnesota's numbers in this area compare to other states. We're not in a position to fully analyze what is happening nationally or in 49 other states, but there are a variety of approaches being used in other states to elevate and track COVID deaths in long-term care facilities. And here in Minnesota, we are being very aggressive about monitoring for them. For example, not all states are doing post-mortem testing that we have done on some cases to ensure that we're capturing COVID deaths. Differences among states make it very difficult to draw conclusions about the numbers we're seeing. We do think it's very unlikely that there's anything different about how the virus is behaving in Minnesota, or that there are any significant differences in the vulnerability of our long-term care residents, or how our long-term care facilities are responding compared to those in other states. We feel confident that our data on long-term care represents a good indication of how many long-term care COVID deaths there have been, and regardless of how other states are tracking, reporting, or responding, those totals show that we have to continue our focus on preventing and responding to the outbreak. And with that, I will turn it over to Director Joe Kelly.
Thanks, Chris, and hello again, Minnesota. Good afternoon. Kevin Reed is my Deputy Director at Minnesota Emergency Management, and a few months ago, before all of this started, he adopted a theme for Fridays that our organization now knows as All Good Fridays. The idea is to focus on positive things and good news stories as we wrap up the work week, and while we know that the virus doesn't care what day it is, and frankly, most days I'm not sure I really know what day it is either, I want to use Kevin's theme and share some good news stories with Minnesota today. I'll start with a very short, simple, but beautiful thing that got my day started today. And very early this morning, I made a cold call to my public safety colleague and friend, Colonel Matt Langer, who's the chief of the Minnesota State Patrol. And he picked up immediately and said, "Good morning, Joe. How can we help?" So Matt got my day off to a great start just by being positive and supportive without any condition and without any questions. And that's what being a good Minnesotan looks like, and that's made this Friday get off to a good start. But in other good news, more technically or bureaucratically, about a month ago when FEMA issued our major disaster declaration for the pandemic, Governor Walz asked them to authorize an additional program to help take care of people. You might recall we asked the federal government to provide funding support for what's called crisis counseling assistance. And that program helps individuals cope with the psychological and emotional effects of an incident like the coronavirus pandemic by providing community-based outreach and educational services. It supports short-term interventions to help us all understand our current situation and our reactions to it, mitigating stress, reviewing recovery options, promoting the development and use of coping strategies, and just building other emotional support and encouraging us all to make connections with people and agencies who can be helpful to us. So I think by this point in the pandemic, we can all relate to and tell our own stories about stress, anxiety, fear, and all the other emotions and reactions that that have come with this pandemic. Things like losing a job, worrying about paying your rent or your mortgage, not being able to go to school or have a proper graduation ceremony, that lost sports season, canceled or postponed family events, and of course, worst of all, the death of a precious loved one. Those are all among the many stressors caused by the outbreak, and I'd be surprised to meet someone who isn't feeling some of those effects. So that's why we asked for that program. Our request has been, quote, under review, close quote, for the better part of a month. And the good news is I think we should very soon get notified that our request has been approved. On Tuesday, the President delegated authority to authorize those programs down to the FEMA administrator, and I think ostensibly to get those requests from dozens of states like ours out of that usual review process and move them forward so that we can start helping people that need some support during these times. And I know that the FEMA administrator is now quickly working through those requests. I know they have everything that they need from Minnesota, and I know that we meet the criteria for approval. So I think we will know very soon that this important program will be available to Minnesotans feeling the strain of the pandemic. These support services will be provided at no cost and are really available widely to anyone impacted by the disaster. Our State Department of Human Services has managed this program in the past, and they'll work with mental health providers and others to conduct outreach to find those who need support. And we've been working on this for the last month or so on exactly how to conduct that outreach and deliver effective services while maintaining social distancing. I think we've all heard about telemedicine and about things of that sort that have been had been adapted during the pandemic, and I imagine that this program is going to be the same way. So among the good news this Friday, then, is that help should be on the way very soon to those who need some mental or emotional support to cope with what we've all been going through. And I look forward to confirming that with you all very, very soon. So I'll kick things back to Mike Schomer now for the Q&A portion. Mike?
Thank you, Director Kelly. We'll open it up for questions now, and as we do, I'll ask reporters to limit questions to one primary and one follow-up, and that we limit the number of questions from each outlet so we can get to as many as possible. With that, operator, we're ready to take questions.
Ladies and gentlemen, if you have any questions at this time, please press star, then the number 1 on your touch-tone telephone. If your question has been answered or you wish to remove yourself from the queue, please press the pound key. Again, to ask a question, it's star, then the number 1 on your telephone keypad. Your first question comes from the line of Mr. Theo Keith from Fox 9. Your line is open, sir.
Hi, Commissioner and Chris. A couple of questions here about long-term care facilities. We are hearing from the long-term industry that there are several facilities that are, their words, on the brink of staffing issues where they will not have enough staff to take care of residents. Can you tell us how many facilities does MDH know of that are in this position and what's being done about it?
Hi, this is Commissioner Malcolm. I'll take the first step there. I don't believe we've got anyone on the call with us today who's directly involved in the long-term care team at the State Emergency Operations Center, but as I think we've covered in a call earlier this week, that is one of the things that we've been standing up is a team down at the SEOC that can be more immediately in touch with facilities and able to mount more of a rapid response. And I think they are actually in daily contact with people in the field to know what might be coming in terms of a staffing crisis situation. And they do work to try to anticipate and support that on a pretty real-time basis. In addition to that kind of crisis response, but I'm sorry, I can't personally tell you how many or which facilities that might be, but I know our team has worked just really, really hard to be able to support those facilities when that happens and to help cover shift and the like. In addition to that crisis response, though, which we acknowledge and are working hard to get better at being able to do that rapidly, we also know that we have to take a more systemic approach to this and come up with some longer-term durable solutions for some of these staffing challenges, because it's very clear that we need to continue to anticipate that. So we're looking for all kinds of different ways to buttress the available staffing for long-term care. We've talked about working closely with our colleagues in acute care to be able to bring some staff in that may be not fully utilized in acute care right now to help support long-term care and so forth. So that all I can tell you is that this is very much on our radar screen, and we're working both on the kind of the crisis response, but also some longer-term plans that we hope will be helpful, because we know this is going to be with us for a while, unfortunately.
Thank you. Follow-up to that. You said today in the Senate Family Care Committee that there was one facility that had 157 confirmed positive cases. A number like that has been reported for St. Therese in New Hope. I'm wondering if you can tell us what's the next facility after that? How many cases is the next facility? Because you were making mention that many facilities have very few cases, but what's number two after 157?
That's absolutely correct, that there's a pretty sharp distinction between, I think there are 20-some facilities that have 20 or more cases, and the great majority of facilities have one or two. No, I wouldn't say the great majority, but over half of the 200 and some facilities, and I would ask Chris to chime in at any point on specifics that I may be missing. But the percentage of facilities with two or more cases is over half, and as I mentioned in that same committee this morning, the number of facilities with cases is a pretty small share of the total around the state, whether we're looking at skilled nursing facilities or assisted living. So, but back to your question, of those with significant numbers of cases, I mentioned there are about 20 with over 20 reported cases. We're a little reluctant to talk about specifics as that list changes, and as we've mentioned, some of the larger case totals actually might be intentional, in the sense that some of these may be facilities that have volunteered to take more COVID patients because they have some specific capability to do that. And I'm not trying to duck your question, but I truly don't know the status for the next couple on the list that have higher number of cases, whether those are all cases that originated within the facility or maybe in this latter category. So I'm just a little hesitant to give more details without knowing that.
This is Chris Ersman, and I can just confirm that we have 21 facilities that have 20 or more cases, and that of the 244 facilities that have a case associated with it, 99 have just one case, 36 have two cases. So yes, more than half of the facilities have a limited number of cases, and there are a handful that have more cases. But please keep in mind that as we talk about additional testing in facilities, the likelihood of identifying more cases will increase. And some of the facilities that have a large number of cases are facilities that did test their entire population.
Operator, we're ready for the next question.
Your next question comes from the line of Matt Sepik from Minnesota Public Radio. Your line is open.
Hi there. This question is for Chris Ersman. I believe that you told us early last month, in early April, that you were reluctant to have post-mortem tests done at long-term care facilities just because of a lack of testing, I believe. But just now you mentioned that you have been doing post-mortem testing. What changed there? Is this because of the increased availability of tests?
I just wanted to acknowledge that there are situations in which individuals have been tested post-mortem, and in other places that would not have been done. It's not our policy to say that it must be done, but we know that it has been done, and so I wanted to acknowledge that.
Okay, so how many of these cases that have been identified, is it because there's a post-mortem test done, or have they been tested before they pass away? How is that confirmed typically with long-term care?
Most of the cases, the vast majority of cases in long-term care are cases that were identified with COVID and then subsequently passed away. There have been a few cases in which someone was suspected to have COVID but had not yet been tested and died. And then in some of those situations, we've been able to test after the fact, but wanted to acknowledge that.
Okay, and then just another follow-up question here. When do you plan to do the next run of the university's predictive model? I know, Commissioner Malcolm, I believe it was yesterday that you said it would be soon. And when that model is run, what parameters will change, and where will we be able to see the results?
Sure. Thanks, Matt. Thank you for coming back to that. I know people are very interested in the model, and as I'll just repeat what I said in an earlier session this week. We actually care a lot about the kind of the validity of the factors, and are really interested in why there is divergence among models generally, and what can we learn from that. So we decided, or our colleagues at the university decided, in what they're referring to as version 3.0 of the model, of the Minnesota model, that they put that out for peer review to some research leaders in the field around the country to get some feedback on that. So that's why the delay, if you will, is that before we rerun model 3.0, we wanted to get some peer review on the assumptions. So that, I'm told, they're anticipating being able to rerun the numbers with version 3.0 sometime next week, middle of the week. I'm anticipating, and certainly we will make that publicly available on the COVID-19 website as soon as it's available. I think, and certainly we can do a session on it, or have Dr. Gildemeister. Actually, he corrected me last time I called him doctor. He said that was a promotion. So. Our wonderful state health economist, Stefan Gildemeister, we can have him join us for one of these calls next week and go through the new data.
That would be great. Thank you.
Your next question comes from the line of Emily Havoc from Care 11. Your line is open.
Hi, Jan and Chris. Thank you for doing this. I have a question. Looking at some of the breakdown of the cases and deaths in long-term care. You've said before that you don't recommend at this time that families remove their loved ones from long-term care facilities, but looking at the fatality rate among those 80 and older, it says 34% fatality in long-term care, 18% not in long-term care. I guess, what's the argument against a family taking out their loved one if they can take them home, and what would you say to those families?
Thanks, and this is Jan. I'll let Chris certainly chime in on this as well. But I think what that data reflects is that we know that the health status of elders and others with various complicating conditions who are in long-term care facilities have more fragile situations than their similar age peers who are still living, in their own homes or with family or what have you. That's not always true, obviously, but as a general statement, we know the health condition of folks in facilities is more fragile than those outside. So I think that accounts for the majority of that difference, rather than concluding that the difference is the risk inside the facilities. Though we have acknowledged that that these are facilities in which the disease can spread, just as does any disease. I mean, we work hard on the spread of infectious diseases in long-term care all the time, whether that's seasonal influenza or other common easily transmissible infectious diseases. And Chris can certainly comment much more on that. C. difficile and just a lot of things that can pose health risks for the elderly. So what we've said about the safety of the long-term care environment in general, we continue to feel is the case, that again, the majority of facilities, whether they're nursing homes or assisted living, have done an excellent job of preparing and preventing, and there are not cases in every facility. And it's just important to keep reinforcing that these facilities, their staff are working so hard, their administrators are working so hard to keep their environments safe. And those who are managing, and I'd like to say with our help, but they're doing the hard work of applying the infection control procedures and the enhanced cleaning and all the rest. They're successfly managing to prevent the spread in many of these facilities that have had only a couple or one or two or a handful of cases. So we're watching, we're really trying to work with all facilities to prevent the spread as much as we can, and again, just keep wanting to draw attention to the success stories where that is happening, and which is not to minimize the importance of working with those who have had larger numbers of cases, and partly, I think, Chris, you might want to comment on this, but that also reflects how much we have learned over the last 6 weeks, and it's kind of amazing to remind ourselves that we're talking about a 6-week span of time since we saw the first confirmed cases in long-term care, that we didn't know at that time about the role of asymptomatic spread. We, I think, didn't have some of the resources in place that we do today. We didn't have as much kind of active engagement with those facilities early on. So I think that the facilities and we are working hard to support them and make these environments as safe as we can for the residents as well as the staff. And we just know that moving folks out of settings which have become their homes can be very dangerous and disruptive as well. And I went on way too long there. So Chris, if you have anything more to say, please do.
The only thing that I will add is just to reiterate that it's not necessarily the setting that is the difference in terms of case fatality rate for individuals in long-term care versus not being in that setting, but it's the characteristics of the individual that have gotten to them to that point that they're, as the commissioner said, they're not able to remain in their own home or whatever. They need that additional care. And then the other thing that I want to acknowledge is that there's probably a reason that families have not been able to care for their loved one at home, and it's because of the specialized care that is needed for that individual and provided through the long-term care setting. So when families are weighing, these difficult decisions at this difficult time, they need to keep in mind that their family member is getting certain special cares through the long-term care facility where they're staying, and if they're not able to provide that level of care, that's a consideration. And it's not a short-term situation. It's not, well, if we could just take mom or dad home for the weekend, that would make a big difference. This is months and months. So those are all things to just make sure that people are thinking about as they're thinking about this type of situation.
Thank you both. Really appreciate that. And a follow-up question here, just do you have data on when these deaths are happening that are listed as in long-term care? Are those actually happening in long-term care facilities, or are those people, some of those people being treated in ICU and dying in ICU?
I can take that one. Yeah. So individuals are listed as or counted as a long-term care facility death if that is their place of residence. And so there are some individuals who are ultimately transferred to acute care to receive services and pass away in acute care. Many residents do pass away at the facility that's their home. And keep in mind that a number of individuals will have chosen their end-of-life, have made end-of-life decisions, do not resuscitate, do not intubate, and have asked to not have extensive interventions. So all of those things play into this. But yes, some individuals are moved to acute care and receive care there and pass away. Some individuals pass away at their residence, and then we need to keep in mind that that there are individuals who have made end-of-life decisions that influence how they are cared for.
This is Jan. I'm just going to jump in there. Thanks, Chris, for mentioning that. I was going to say the same. That just how important it is that all of us, individuals and families, are clear about our end-of-life wishes. And we've actually heard from a number of family members, as well as providers and facility staff, that they're a little concerned. That some of these folks who have passed away have been actively dying of something else, and it's still they have COVID, and so they're counted as a COVID related death. But in point of fact, one could certainly justify counting that as cancer or something else. It's more than one thing. COVID might have been the immediate cause, but I think you get the point. So I do think that's a really significant part of this story. This is hitting the very elderly and people with underlying health conditions really hard, which is not unexpected, and we need to do what we can to mitigate that risk. And we need to understand that some of this is happening very much in the context of individual and family wishes for how they want to be treated.
Thank you both.
Your next question comes from the line of Bill Warner from Minnesota News Network. Your line is open, sir.
Hi, thank you, Commissioner, and others. And this, I want to focus in on a comment that Senator Ralph made in the hearing today, and I know, Commissioner, you and Director Erzman were both on that call. He was referring to facilities where there are potential staffing problems in terms of implementing health department recommendations, and he said we have to try to focus on those facilities. Otherwise, we're going to continue to have these large outbreaks, and then those staff are spreading it throughout the community. And that last part of what he talked about is something I want to focus in on. And I understand this would not be intentional on the part of staff members in long-term care facilities. But is there evidence that spread is occurring between long-term care facilities? I know that staff members work at various facilities. And if so, given the staffing shortages, what can you do, or what are you planning on doing to try to get a handle on that? Thanks,
Bill. I think that the senator's question was a good one, and we agree that these are all the reasons why this certainly deserves continued vigilance and the development of going forward strategies. What have we learned? I've mentioned a couple times the facts are different. Our understanding is different than it was 6 weeks ago. So how can we use all of that knowledge to try to keep pace with and stay a step ahead of this if we possibly can? So I think that is why we're looking more closely at what are the right right protocols for how staff health is monitored. What is the role of testing? among residents and among staff, and those are all things we're continuing to look at. Chris?
I would just add something that we've commented on before and the Commissioner alluded to earlier, and that is that over time, not that long of a time, but since we started dealing with COVID-19, we have learned more about the role of asymptomatic transmission. And so now as we're interviewing cases and looking at their infectious period, that includes 48 hours before the onset of symptoms. And so that in and of itself can unwittingly contribute to transmission. Someone could be working without symptoms and not realize that they had COVID. So I just want to acknowledge that when we talk about transmission from staff or even potentially between facilities, because we know some staff work at multiple facilities, that there is a role that asymptomatic transmission plays. And so we have to recognize that when we talk about that, we're not suggesting that staff are blatantly coming to work with symptoms.
Just a quick follow-up, if I may. What is your confidence level at this point? And I understand a person can't be 100% confident. What's your confidence level of whether spread is occurring between facilities, unwittingly, certainly, by staff members? And what do you need to do to get your confidence level higher on that that's not happening?
Chris, I'll let you take that one.
Yeah. Bill, what I'd say is that, remember, we have COVID in the community. So it is occurring many places. We're seeing it, when we identify cases and we look further, we see more and more cases. So I think we have to keep in mind that we're seeing COVID in facilities because it's in the community and it is being unwittingly spread. So it's not that it necessarily has to spread from one facility to another as if it's not occurring in other places. We've focused our testing on these facilities because we want that information so that we can be aggressive in working with facilities so that we can increase the proportion that just have a single case or two cases. But it's happening everywhere, and so I just want to put it in that context that I'm confident that it's in the community, and because of that, we have to be on our guard for these long-term care facilities.
Okay, thank you both.
Your next question comes from the line of Dave Orick from Pioneer Crest. Your line is open, sir.
Hi, thank you. This is kind of a dumb question, I guess, and I wish the governor were on the call today, but Commissioner Malcolm, as we've gone from yesterday and I've digested this and answered questions from the public and my friends and looked at we're close to 5,000 tests, it keeps coming up. Why do we have to extend the stay-at-home order another 2 weeks?
Well, this is Commissioner Malcolm. I don't think that's a dumb question at all. I don't think any question is dumb. This is an unprecedented event, and I think we fully appreciate, as the governor has said, the full recognition of the disruption that the stay-at-home order is causing economically, and just in the interruption of what matters a lot to all of us in terms of our ability to engage in activities that are so very important. So that it is not a lightly taken decision by any means. And I know you weren't suggesting that it was, but I think from my perspective, and I think Chris just alluded to this, we do have sort of an index of caution around the fact that we are seeing the case numbers increase rapidly. We are very sobered by what's happened in some of the specific communities in Minnesota, that we see how rapidly cases can spread, and at a time when we feel like we're just really getting our arms around the true spread of the disease, there's some reluctance to open up more broadly when we feel like we could be just on the verge of a of a tipping point, the likes of which we've seen in other communities. So the national guidance, I'll just remind us that the federal government's guidance says you shouldn't be opening up until you've seen 14 days of consecutive declines in cases. We're a long way from that. And I think the governor has said, and I agree, that even though there's some clarity that comes with a definitive quantitative measure like that, he feels that that's not the only measure that we should be using. So we're taking a more, I think, multifaceted approach to adjusting the stay-at-home order as we go. But I hope that's somewhat responsive to your question.
It is. Thanks.
Operator, we have time for one more question.
Your last question comes from the line of Glenn Howard from Star Tribune. Your line is open.
Hi, thank you very much. We have two things going on. One is more testing, which leads to more cases, but also a gradual opening up of some of the economy. With these two things happening concurrently, will MDH be able to measure whether the opening up is actually creating more infections? And I know part of your answer will be contact tracing, but your own data shows that about 15% of transmissions are community where a contact was not identified, and you also have a big chunk, 34%, where it's an unknown or missing exposure. So will you be able to see if there's a blip in cases caused by the opening up?
Glenn, this is Jan. I think that's a really good question, and it's part of our conundrum is that very thing. While we're on the upslope of the epidemic, it is going to be very hard to tease out what's driving what. Which again, to the answer to the prior question is kind of just some of what factors into saying what is your confidence level that we really have a good line of sight to whether things are under control, and how well are we going to be able to respond to these hotspots as they pop up to prevent it from becoming a larger community-wide exponential rate of increase. That's the hope, certainly, but what's our confidence level in our ability to do that is a big part of the question. So we do have other ways of looking at data, of spotting trends, and I'd invite Chris to see if she has anything else she'd want to call out in that regard. So it's not just testing results that we're looking at, but it is, we're going to have to take kind of the macro holistic picture, and it's not going to be really very possible to say this one move, produced X% more growth than there otherwise would have been.
Right. Thanks, Commissioner. I think I want to acknowledge that, yes, we are doing more testing. We're also doing more focused testing. So in other words, as testing is opening up, we focus on long-term care where we were concerned and knew there could be cases, wanted to intervene. We've also done a lot of testing in facilities where we know that there have been cases and there's been the likelihood of spread. So I want to keep acknowledging that there is additional spread that's going on beyond just what we're identifying. So I think that's really important to even though testing is ramping up and it's going to be identifying more cases than we've been able to do in the past when we couldn't test everyone, it's not going to cover every single case. So we know there is activity in the community. And then the other message that I want to reiterate is that we're really glad that we have the ability to do testing and that we can do more testing and that we can identify cases and their contacts and make recommendations. But the bottom line is that our recommendation that individuals who are sick need to stay home is true regardless of whether or not we have testing. And I just want to make sure that we don't have people thinking, well, if I got tested and I found out I had COVID, then I need to stay home, but, I'm not doing that, and so I'll just go about my merry way. No, we really need people to take the stay-at-home if you're sick message very seriously, and obviously our goal is that symptomatic individuals can be tested, but until that is completely realized, people who are sick need to stay home, and that's going to make a huge difference in slowing down transmission.
And quick follow-up, how are you doing on contact tracing in terms of responding to cases within a day?
I would say that we're becoming more challenged as we're working on situations in which, for instance, with the JBS situation, there are 58 different languages amongst the workers from that plant. And so even with language line and interpreters, that can make things challenging. So we're not in every case are we able to contact people within 24 hours.
And I think Chris rightly points out the complexity of this, and it's also what's kind of going to require us to think about some ways of augmenting our traditional approach with not only additional staffing but just additional ways of doing that more extended contact tracing function. The role that technology might play in that, remains to be seen. But there's a lot of work going on all around the country really quickly to develop new models of expanding this capacity. And I think we're taking a really close look at what some other states have done to ramp this up quickly.
Thank you, Commissioner Malcolm, and thank you to everybody who joined us for today's call. If you didn't get a chance to ask a question but would like to follow up, please feel free to reach out to MDH Communications at 651-201-4989. Thank you, and we'll talk with you again soon.
Find more local news stories at ccxmedia.org and follow us on social media.